Okay, hi everyone. Okay. All right, hi everyone. I'm not sure if you heard me or not, but I'm going to do a quick run through of the anxiety PowerPoint. I just want to make sure that you definitely understand the key points, okay? So let's go to this slide on true or false. All right, so anxiety. Anxiety is one of the least common human emotions. So do you think it's true or false? All right, so hopefully, this is false. Anxiety is one of the most common human emotions. Okay. And okay. All right. So I'm not sure where we were. Anxiety is always okay. So anxiety is always maladaptive. So no, anxiety is not always maladaptive, right? So if you're walking down the street and you're like, oh, maybe I should go down this alley, and then you get this sense like, maybe not. You feel a little anxious about it. Or if you're about to go on a date with someone and you just get this funny feeling in your stomach, that's that anxiety kind of feeling. And it kind of sometimes can tell you you're in danger, okay, or something is not right. But also sometimes when you get anxiety, it also is an indication to pay attention to your emotions. Like, what are my emotions trying to tell you? It can almost be like a guidance system, okay? All right. So a high level of anxiety can interfere with perceptions, memory, judgment, and motor responses. True or false? This is absolutely true. Okay. And in terms of memory, when you're anxious, you can be overstimulated. So with anxiety, there's an increased alertness that can interfere with the brain's ability to store new information. Okay, your cortisol increase in your cortisol levels, which occurs with anxiety because anxiety raises cortisol. This can damage or interfere or disrupt parts of the brain that are responsible for memory. And what parts of the brain is that? You should know that. Okay, I'm not going to tell you. All right. And then working memory. Anxiety makes it hard to hold on and work with information, such as remembering tasks, right? It's a funny thing too, because sometimes, anxiety can, hold on a second. All right. So anxiety can make it hard to hold on to and work with information, such as remembering tasks. So sometimes anxiety can significantly interfere with your working memory. Now, if you remember in ADHD, when it comes to ADHD, people with ADHD sometimes have poor working memory. And so you may be presented with a patient who has symptoms of ADHD, but also has symptoms of anxiety, and you're not sure which is what, because there is this overlap, right? Particularly related to memory and avoidance of tasks. And so how do you discern whether or not it's ADHD or anxiety, or is it both? And this is where you'll look at your diagnostic criteria and you'll start to assess, particularly for ADHD, when did these symptoms start? What did you experience in childhood? And there's a whole host of other symptoms that you can rule out or rule in to let you know what is the most probable diagnosis. Now, why does it matter? Because if someone has ADHD and they're struggling with poor working memory, well, you could potentially put them on a stimulant, especially if they have other symptoms. But if someone is having poor working memory because they're anxious, well, then you're going to put them on maybe an SSRI. And keep in mind, don't forget that there are some SSRIs. Well, actually, we're not going to go there yet because that's when we talk about ADHD, but there are some antidepressants that are somewhat effective for ADHD, and they are in the category of SSRIs or SNRIs or serotonin, norepinephrine, dopamine reuptake inhibitors, something to that degree. Okay. All right. So that being said, next, so we talked about memory. Okay, judgment. Anxiety can cloud the judgment, okay, because you're so anxious, you're focused only on potential dangers. And so this can lead to a bias or poor decisions. If you're anxious to get into a relationship, you may see everyone as potentially a threat. If you are so anxious to go outside, you may not go outside and wind up not living your life and becoming a shut-in. Okay. So anxious people often focus only on potential dangers. And this does lead to a bias, a negative bias. Also, anxiety uses up a lot of quote unquote mental energy, right? So it makes it harder to think clearly or solve problems, particularly chronic anxiety, okay? And then when it comes to motor responses, in general, people with anxiety usually have a lot of muscle tension. And this muscle tension or muscle tightness is because their sympathetic nervous system is getting them ready for action. Okay. Because remember, you're gearing up, your muscles are stimulated, your muscles are ready to go, ready for action. Okay. All right. So people often experience anxiety as a somatic or physical concern. This is actually true. Okay. But it's important as psychiatric practitioners to assess the person in totality. So just because a person is anxious and says that they have a stomach ache, because remember, when your anxiety is fear, okay? And when your fear system is activated, your sympathetic nervous system is activated. And if you remember from before, and if you don't, look it up, when your sympathetic nervous system is activated, certain things occur. Your heart rate goes up, your respiratory rate goes up, and your digestion can sometimes slow down. So people feel like a change in their stomach. There's this pit feeling that people get in their stomach, and it's because their nervous system is activated. Now, just because someone is complaining of anxiety and does have this pit in their stomach, it doesn't mean that you should bypass a medical assessment. All right, because there could be two things can be occurring at one time. Okay, so I'll give you a little story. I'm not sure if I told this story before, but my grandmother, as she got older, she fell a couple of times and she became very, very anxious to fall. And then the anxiety spiraled and it got worse and it got worse. Okay, so she was very, very anxious. And she used to call my mother almost every morning while my mother was getting ready for work, saying that she had such severe stomach pain, that her stomach hurt so much and something was wrong. And everyone, including doctors, perceived this as her anxiety just getting worse and worse and worse. So let's treat her with some Lexapro. Let's give her this medication. She complained so much, and for so many years, finally someone did a colonoscopy on her, and come to find out that she had a severe blockage. And so we need to be diligent, and we need to do a whole assessment. And as a psychiatric nurse practitioner, this is what makes us different than psychiatrists. Okay. Yes, we're still prescribing medications, and to some degree, there's a lot of correlation. But us as psychiatric nurse practitioners, we look at our patients holistically. If a patient is having stomach complaints and we understand that there's anxiety there, we're still going to assess for something else. We're still going to be very, very thorough and holistic in our approach. Okay. All right. All right. And then psychotherapy only is the first line treatment for patients diagnosed with an anxiety disorder. Is this true or false? So this is false. Okay. Therapy as a first line treatment only is recommended for minors, not adults. Okay. For adults, treatment considerations for adults is based on the level of disability and the interference with functioning. So yes, do you want to give someone an antidepressant, anti-anxiety medication? If it's necessary, if there is a level of disability in their life, in their functioning, are they able to work? Are they able to go to school? Are they able to leave the house? Okay. And then also, if not, maybe you do start with just a referral for therapy, or maybe you go on and get additional training and learn how to do CBT therapy and different types of exposure therapy and anxiety-driven therapies, okay? I don't know if I said this before, but with medication, SSRIs and medications, these medications are usually very, very safe. But how patients respond to medication is like a bell curve. You're going to have some people under the curve, which is the average person that doesn't experience anything. And then you have the outliers who experience very severe side effects. And you rarely ever know who is going to be that patient that has a severe adverse reaction. So when you prescribe medication, you want to make sure you educate your patients. You make sure you give them a copy of the information, let them read through it, tell them, look out for this, look out for that. If this happens, stop taking the medication. But you also don't want to act like you're just giving them some chewing gum, okay? These medications are processed through your kidneys. They are processed through your livers, I'm sorry. They have a lot of interactions with other medications. Some people have gene drug interaction, which you'll get into towards the end of the semester. The point is, take it serious. And if a patient feels like they're uncomfortable with medications and the level of debilitation is not where they're a danger to themselves or a danger to others, they have the right to make that decision. You can encourage them, particularly if you see them ticking or trending down a path where they're going to lose their job, they're going to fail school. Absolutely. But respect your patients, okay? All right. Okay, so let's just make sure the mute is not on. All right, so let's look at this case study. Okay, Maggie is a 29-year-old nursing student in her final semester. She's scheduled to deliver a 20-minute presentation on CHF in 3 weeks. Since learning about the assignment, she's been feeling extremely anxious. Maggie struggles to sleep at night due to thoughts about the presentation and finds it hard to focus at work, where her mind is consumed with worry. Despite maintaining a 98 average, she's seriously considering withdrawing from the course as her anxiety is overwhelming her. Okay, so let's look at the considerations. Is this normal anxiety? Is this disordered anxiety? So, is it normal to feel anxious because you have to give a presentation? For many people, it is quote unquote normal. Okay, and many people will feel very anxious. But Maggie is struggling to sleep at night due to thoughts about the presentation. So this is impairing her functioning. Okay, she's not able to sleep. All right, it says she's finding it hard to work because she can't focus. So it's impairing her work. So there is a level of debilitation that exceeds what is normally would be a normal anxious response. Okay, her response is disproportionate to the event. All right. So you know that there's a level of debilitation. There's a level of disordered pathological anxiety here. Okay. There's an impairment in function. You want to look at the root cause, right? What's driving this anxiety? All right. Did she have an episode, like maybe she had to do a presentation 2 weeks ago and she fell while she was going up to do the presentation? Or maybe she's always had a baseline of anxiety and this is just exacerbating this. Maybe she was really, really criticized in childhood and so she had experienced ACE events, adverse child experiences. Maybe she's experienced ongoing chronic anxiety. Maybe she avoids things. You don't know. You won't know until you do your assessment. Okay. All right. So really quickly, I want you to take a look. If you haven't done so, I want you to look at the different disorders under anxiety in the DSM-5-TR. And so this is where you look at generalized anxiety disorder, social anxiety, agoraphobia, panic disorder, specific phobias, et cetera, et cetera. Okay. And so when you have a patient who has experiencing some level of debilitation related to anxiety, what's gonna be the goals for this patient? All right. So you can assess, is this normal versus disordered pathological anxiety? What your goal is to decrease anxiety and improve functioning. And how are you going to go about doing that? And again, it's going to depend on what is driving the anxiety. So let's think about Maggie. So now let's say Maggie's anxiety related to this presentation is because she experienced a couple of weeks ago or a month ago or 6 months ago a dramatic incident where she went to do a presentation and she fell or she forgot everything or her dress ripped, whatever. Prior to that, she didn't experience anxiety and she doesn't have anxiety in her daily life. It's only related to a performance. Okay. And so this is a performance anxiety. And why it's so important to differentiate this from more of a generalized anxiety, because how you're going to treat this in terms of the pharmacological interventions differs. So for someone who has a performance anxiety where their only experience is this anxiety when they have to go and do this presentation. It's only about this presentation, some performance, et cetera, et cetera. You would give them something like propranolol. And remember, propranolol is a beta blocker, which calms down your sympathetic nervous system, which activates your parasympathetic nervous system, right? And your sympathetic, this is your fight or flight response. Everything is elevated. Cortisol goes up, digestion slows, but cortisol goes up, heart rate goes up, blood pressure goes up, et cetera, and you start to feel the physical symptoms of anxiety in your body. So if you give someone a beta blocker a half an hour to 45 minutes before a performance, the person will feel internally anxious, like, oh, I'm scared I have to give this presentation, but they won't experience the physical they're less likely to experience the physical symptoms of anxiety in their body. So you're in school, you've seen people give presentations, and you might be that person where the person is holding up their paper and they're just shaking. Now, it might be different because everybody does things on their phones these days, but in my day, people were just holding their paper and shaking. And it doesn't matter how prepared these people are, their body just goes into this fear response. So you give them the beta blocker, and even though they're anxious, they won't shake. Their voice won't crack. Their skin won't flush. They won't sweat profusely. They won't have the heart palpitations. And what happens is, once that happens and they realize, like, hey, I guess it wasn't as scary as I thought it was, the next time they do the same thing. Eventually, they'll be able to give the presentation without going into the fear response, because now their brain has learned that this is actually not a life-threatening situation and there's nothing really to fear. Okay. Now, let's say Maggie has had experienced anxiety most of her life, off and on, or even just for the last 5 years, off and on every day. She worries about things besides this speech. She worries about the world. She worries about her job. She worries about this. She experiences anxiety on a day-to-day basis. She has a sense of impending doom. Well, then most likely she's going to meet the criteria for the diagnostic criteria for generalized anxiety. Okay. And so we want to look at your SSRIs, right? And so we're going to look at Lexapro. Okay. Now, if you remember, Lexapro has been shown to be effective for generalized anxiety, for anxiety. Then you have Zoloft, which again does well for anxiety and depression, and it is quote unquote clean drug, if you will. It doesn't have as much interactions as other SSRIs, and is less likely to interact with medication and less likely for a patient to have side effects. So you have the Lexapro, the Zoloft, and then you have Paxil. Now, Paxil, if you remember, has the shortest half-life. So if a patient skips a dose, or if they're late, they're most likely to start to experience discontinuation syndrome. And remember what that is, right? And so, the Paxil is really not going to be used for your day-to-day generalized anxiety. You're really going to use your Paxil for severe social anxiety. And again, that's if the other medications like the Lexapro and the Zoloft are not that effective, or there's some contraindication, because with the Paxil, there is a higher risk of discontinuation syndrome. Now, if you have somebody who's very diligent and they're going to take their medication all the time, okay, then you can think about it. All right. And then you have Luvox, which I've mentioned before, is prescribed for OCD. Now, I don't know if I said it, but a lot of times providers now don't want to prescribe Luvox as the first line for OCD, because Luvox is a dirty drug and has a lot of interactions. So you want to make sure you do a full medication assessment, okay? And make sure that if your patient is on any medication, there's not any interactions between that medication and the Luvox. All right. Just a side note, also another good medication for Luvox or evidence-based medication is anafranil, and that's a TCA. Okay. What else? Also, Prozac is FDA approved for OCD, but usually Prozac is helpful at higher doses. Now, this is just an antidotal. What I'm about to tell you is antidotal. Okay. So in my experience, I found that people who have bad OCD, like they have to count 10 times before they go up the stairs, or they feel like they're going to have a heart attack, or their nails have to be done all the time. If they drive, they have to have like perfect nails, or else they feel like they're going to have a car accident, or a person has intrusive thoughts that they kill someone even though they never did, and it's just very intrusive, or sexual type of thoughts. So, and you'll get more into OCD as you, again, progress in the course and do your assessment and do your clinicals. But so sometimes Prozac is helpful for OCD. In my experience, the more severe the OCD, the less likely Prozac will work. Honestly, anafranil is the best, but because it's a TCA, it's usually not the first line people try. Okay. And then also Zoloft is indicated, but I wouldn't try Zoloft as a first try. But you know, it depends. What has your patient tried before? What medications are your patient on? Okay. If the patient has a mother who has OCD, is doing very, very good on Zoloft, you might consider Zoloft. Okay. So it's just very nuanced. Okay. And this is an art. You have your SSRIs, these are the medication, and you try to make the best decision possible. Prozac is super stimulating. If you have somebody who can't get out of bed and you give them Prozac and it works for them, it will do much better than if you give them Luvox, okay? Somebody who has really bad OCD, if you give them Paxil versus Luvox, 9 times out of 10, they're going to do better on the Luvox, okay? So again, you will learn in general what to prescribe when, and then you will start to learn from your experience. That's why it's so important during the first 2 years of being a psychiatric nurse practitioner to work someplace where you get good experience before, if you decide to go out on your own. Okay. I'm about to end this video. I just wanted to go over those few things. We are nurse practitioners again, so we are looking at the nursing process. Okay, we are looking at the assessment. We want to see when the patient, we'll look at the HPI. When did the symptoms start? How long did they start? Is this just a one-off because of the presentation, or is this a long-standing thing? Has the patient been medicated before, et cetera, et cetera? What are their symptoms? Are they having physical symptoms? Are they ruminating? And you want to document that. Your mental status exam. How does the patient appear? How's their grooming? How's their eye contact? How's their speech, right? So you look up the psychiatric mental status exam, which is different than the mini mental status exam that we do, ANO times 3, et cetera, et cetera. Okay. Current and past medication, medication history, any other psychiatric comorbidities or medical comorbidities. Is the patient self-medicating? Are they using substances, benzo misuse, tobacco, okay? And here you have a link to the GAD-7 and the HAM-A, and this is your screening tools, okay? So you want to make your diagnosis. You conducted your assessment, okay? You're going to look up the DSM-5 TR chapter on anxiety, and hopefully you're going to read through the different disorders, okay? You want to see what disorder most likely describes your patient's symptomology, okay? And you want to think about, I apologize. Okay. All right. You want to do your baseline lab work. Okay. You want to rule out any medical conditions, any cardio. Is there CHF? Is there arrhythmias? The patient has COPD. Does the patient have asthma? Are they using substances? And that's why they're so anxious. And this is on presentation, particularly like in an acute setting. Okay. I'm sorry. All right. In terms of lab work, right? So your baseline, what's your baseline? Your CBC, your CMP, your thyroid, your B12, because you want to rule out metabolic causes, okay? You want to look at your blood gases, right? So that you can see the body's respiratory and metabolic functions, right? Like, is there COPD? Maybe that's why they always feel anxious. They're not really oxygenating properly, okay? Also keep in mind that other medications such as like sometimes antipsychotics, sometimes steroids, bronchodilators nicotine, caffeine can also increase feelings of anxiety. Okay. All right. So planning, just like anything, you want to think about your symptom dysfunction in your brain as much as possible. You also want to think about the drug, any particular drug interactions in special populations. Okay. Okay. All right. So whenever we're going to implement whatever psychiatric medication we decide to utilize, you always want to start low and go slow, right? Okay. And you want to educate your patient. Okay. And so what are your treatment options? Okay. So we talked about your antidepressants and you have benzodiazepines. Okay. And so your benzos, this is your Ativan, your Klonopin, your Xanax. You really should, benzos are only prescribed for a short period of time. You should never put your patients on benzos around the clock unless there's some other medical consideration that, like maybe the person is on hospice care, or when patients are detoxing off of alcohol, delivery benzo is given daily but eventually weaned off. You don't want in an outpatient setting to put your patient on a benzo every day, because you will create a physical dependency. And when that benzo is withdrawn, the patient could potentially seize. Okay, so benzo are used for very, very short time, a short amount of time, short term. Okay, the problem is, and you'll see this, I have personally found anxiety, particularly panic attacks, very, very difficult to treat, because you have patients who are experiencing 1 to 2 panic attacks a day, and the only thing that calms them down is benzos, but you don't want your patients to be taking 1 to 2 benzos a day. So what do? You find an SSRI that works to decrease their anxiety and subsequently decreases the rate and the amount of panic. Now, you will find patients, particularly patients who have been on benzos for a long time or SSRIs, that say they can't stop taking the benzos because they continue to have the panic attacks. Well, something's not working there. So either you need to add like an antipsychotic to that medication regimen, or they need to go to a different type of treatment. And potentially they need to go to a treatment that has like exposure therapy for anxiety, or has like anxiety specific therapeutic modalities. Okay, so that could be CBT for anxiety. It could be, like I said, exposure therapy. It could even be EMDR, especially if the anxiety is coming from like trauma experiences, but it doesn't quite meet the criteria for a trauma diagnosis. Okay, beta blockers. So this is adrenergic and beta blockers. So that's the propranolol, but also like clonidine. Okay, these kind of calm down your nervous system. And then off-label use is antipsychotics, and then convulsants. So that's your gabapentin. In terms of psychotherapy, we're talking about CBT, exposure therapy, meditation, mindfulness, somatic therapy. This is when you do body work, right? Like if you get that pit in your stomach, it teaches you to identify it, to recognize it, and try to learn to release it. Okay. Psychodynamic therapy, and you'll learn about this down the line. Okay. All right. So pharmacological intervention. So your SSRIs, and this is when I say SSRIs, I also mean Wellbutrin and Effexor and venlafaxine as well. So the pro is that there's no risk of dependency. The con is it can't be used PRN. So it's like when a person feels anxious, what are they going to do at that moment if they're having a panic attack? They can't just take another Lexapro just because, right? It doesn't work like that. It takes time to establish a therapeutic onset. Sometimes it can take 2 to 6 weeks, 2 to 4 weeks. Okay. TCAs can be effective, but the issue is with the risk and the side effects. Remember, with the TCAs. Okay. Then you have benzos. And so benzos can be used to treat anxiety. These are used to treat like acute intense anxiety. So this is your panic attacks, okay? Or like anxiety before a surgery, or anxiety before a particular procedure or something. This is not, you don't want to use this before a presentation. This is, you'll use your beta blockers to calm down your sympathetic nervous system, okay? But with benzos, the pro is you can use them as needed, unlike the SSRIs and that group, the SSRI pluses, and it has a rapid onset. The problem is it's only for short-term use. You can't use it long-term, because if you do, the patient will develop a physical tolerance, a dependence, memory issues, and depression. And the thing is, it's not like the patient is like, oh, I want to have my out of my Xanax today so I could get high. The patient, it's the thing that relieves their anxiety. So it's not like the patient is using it to get high. The patient is using it to mitigate their anxiety. The problem is their body develops a physical tolerance to the medication. And when you withdraw the anxiety, I'm sorry, when you withdraw the benzo, the patient goes into physical withdrawals, almost like heroin withdrawals. Okay. They get cold shakes, they can have seizures. All right. And your benzos are your PAMs, okay? Your lorazepam, okay? Your clonopin, clonazepam. I'm sorry, I have a hard time. Alprazolam, okay? Is your AMs, your PAMs, okay? And so this is your Ativan, Xanax, Clonopin. You'll see sometimes Librium is used for alcohol detox, okay? Right. And then you have miscellaneous pharmacological psychotropic drugs. And so this is your boost bar. Okay. Boosterone. Right. Boosterone is good for anxiety. Sometimes you can use boost bar in addition to SSRI. All right. So boost bar is given twice a day. It's usually not used as a first line intervention. It's usually used as like a second intervention. Again, you have your beta blockers. You have your alpha agonist. This is your clonidine and your guanfacine. And then you have gabapentin and pregabalin, which are your anticonvulsants. Okay. All right, so patient education. I'm not really going to go over this. Okay, so I want you to know this slide. Go over this, okay, for your final. Okay. All right. Okay, and then finally we have the evaluation. So you start your patient on whatever medication, they come back in 2 weeks. What's the follow-up? How did they do? How are you feeling? How's your anxiety? And remember, when you do your assessment, you're gonna look at their GAD-7, you're gonna look at their HAM-A, your HAM-A, and when they come back, you give them the screening tools again, and you see, has there been any change? Has their GAD-7 gone down? Like, are their anxiety scores going down? You want to look at these benchmarks, okay? How do they feel subjectively? How are they functioning in their life? Are they able to focus more in school? Maggie, how was the presentation? What's going on? How are they experiencing any side effects to the medication? Is it making them nauseous? One of the complaints of Boost Bar is that sometimes Boost Bar can cause like GI issues. Okay, so you want to assess your patient, the effectiveness of the medication and the tolerability. And remember, if they come back for a 2-week appointment, you may not have a full therapeutic response, but you still want to see them in 2 weeks because you want to make sure they're not experiencing and then you're going to adjust accordingly. Okay, so your patient returns for a 2-week follow-up appointment after starting Lexapro for generalized anxiety disorder. Consider next steps for each statement, follow-up questions and interventions. Okay, so I take the medication every day and I do not feel better at all. Okay, this means that you didn't educate your patient, right? Because you have to let your patient know it can take 2 weeks, but it can also take 2 to 4 weeks and sometimes a little bit more. All right. Every time I feel anxious, I take the medication, but it does not help. So again, this is a problem with patient education, right? You have to let your patient know Lexapro is not an as-needed medication. You're going to take Lexapro every single day, hopefully at the same time, to make so that you can establish a steady state so you can get a therapeutic level. And then the medication is going to start to work. If you're having panic attacks every day, I can give you something like clonidine to calm down, maybe a hydroxyzine. Okay, I didn't mention that, but sometimes we use hydroxyzine and we'll go over that. Hydroxyzine is like Benadryl, is somewhat sedating, and that bit of sedation can sometimes cause a decrease in anxiety. I think I told you guys I had a patient who was actually in nursing school and she used to take the hydroxyzine twice a day. And I was like, aren't you like exhausted? No, for her, it worked. Okay. So it's different for everybody else. And so how do you know if it's going to work for your patient? Well, you say, hey, this is hydroxyzine. Sometimes it is effective, but I would try it at night first. Or I would try it on a Saturday first, because you don't want to try it when you have a high stakes day, like when you're in school or you're working. Okay. Right. I feel much less anxious, but I'm having a hard time with my husband. And what way are you having a hard time with your husband? Okay. So that's what you want to ask. Are they getting paranoid because is the medication making them feel paranoid and they feel like their husband is trying to kill them? Or is she talking about sexual side effects, which can sometimes happen, particularly with Lexapro? So depending on, if it's happening in 2 weeks, maybe you want to try a different medication. Maybe you explain to the patient, and you should have, again, you have to warn patients that sexual side effects could be a potential issue. It doesn't happen for everybody, but it might happen. So this way they're aware of it, okay? And you want to find out, well, what type of symptoms is the patient having? Is the patient having a hard time having an orgasm? Is the patient just having low libido? And then you respond accordingly. If the patient is doing well on the medication and doesn't want to try, feels like the risk benefit of this medication is okay because she's feeling so much better on the Lexapro, but still is struggling with like having an orgasm, then potentially you refer the patient to the GYN, you refer them to like a sexual therapist, or you encourage the patients to use depending on your relationship, you can encourage the patient to do manual stimulation to achieve an orgasm, or a vibrator, if you're comfortable with that, and if that is the type of relationship you have with your patient. Again, the more comfortable you are with your sexuality and the need for the sexual experience in general, the more comfortable you can make your patient feel. Okay. Because remember, we have hierarchy of needs, and sexual needs is important as well. And you don't want to, a lot of times, especially for women, this need is sometimes ignored maybe, or underestimated. Okay. And it comes with a lot of like judgment and stigma. So again, you have the right to practice how you want to. But if you feel like you have a patient that is having sexual side effects, or could potentially have sexual side effects, and that's uncomfortable for you, and whether that's uncomfortable for religious reasons or cultural reasons or whatever, you just can refer that client to somebody else, or you can start to, explore your level of what you feel is appropriate or what you feel is healthy with a therapist. I encourage all mental health providers to do their own independent work as well. Okay. Because the healthier you are, the healthier you can be for your patients. All right. Okay, so let's see, where are we? Evaluation. So SSRI and SSNRI antidepressants. So safety and lack of misuse concerns. Okay, when we say lack of misuse, we're talking, right? So it's overall safety. There's not a lot of risk of misuse like your benzos. Okay, there's an efficacy for comorbid depression, and a lot of times, remember, anxiety and depression are often comorbid, and sometimes it's depression that drives the anxiety, sometimes anxiety drives the depression. Anxiety is so bad and debilitating, the person starts to have such negative thoughts and a negative perspective about themselves, and before you know it, they don't want to get out of bed, and it just spirals. Okay, general efficacy across all persistent anxiety states. Okay, so what does that mean? Like generalized anxiety, social anxiety, etc., etc. You always want to start low and go slow, but you might need higher dosages, absolutely, and that's what go slow means. Excuse me. The challenges to this medication groups is discontinuation syndrome, initial activation. So it's particularly with Prozac, right? We know that Prozac does have this initial activation, okay? Insomnia, sexual dysfunction, GI effects, and weight gain. And remember, if you have somebody that you start them on an antidepressant and they become they have severe insomnia, they're up for days, they can't sleep, they're talking, racing thoughts, this and that. What do we think has happened? We have triggered a manic episode, which is not, sometimes we have to trigger a manic episode to know that the person has a bipolar disorder. It just happens. And so there shouldn't be like a judgment on yourself, especially if you did a thorough assessment. Have you had episodes? Has there been times that you assess for a manic and a hypomanic episode? And even if you didn't do an assessment, I bet you'll never not forget to do the assessment a thorough assessment again. And so this is a learning lesson, and it does happen. Sometimes you give patients an SSRI and it triggers a manic episode because they weren't diagnosed. And so what do? You get them to the emergency room, and you take it from there. Okay. And if you work in the emergency room, this is the time where you're going to give them some Ativan, you're going to give them a mood stabilizer, you're going to give them an antipsychotic, and you're going to take it from there. Okay. Sometimes you want to augment these medications with the benzo in moderation. When I give patients benzos, I usually give them 3 or 4 for them. It's just so they have something. They usually don't use it. Now, I have a patient who's really having severe panic attacks every single day. We have to see what's going on. Okay. And again, patient by patient. Psychiatry is different than like general medical, primary care, I should say, because, you give somebody an antihypertensive, the blood pressure is going to go down. And there's like a flow sheet. Hey, try this. There's a certain algorithm. Now, some people have created algorithms for psychiatric nurse practitioner practice, but for the most part, it's really going to be your patient, how your patient presents, what your patient's experiences are, what their medication history, their psychological history. Okay, all that is very nuanced. So, benzos, we talked about this, safety and lack of misuse concerns. No, it's not lack of misuse. It's safety and misuse concerns. Okay, I apologize. Please correct that. Benzos decrease the respiration rate. Okay, cause sedation, cognitive and psychomotor impairment. The patient will develop a physiologic dependence with ongoing benzo therapy. And there's also issues with stopping the medication, because if you stop it abruptly, remember there's the potential for a seizure, so you have to taper them very, very slowly. There's the potential for abuse, particularly in predisposed individuals, people with a history of substance use, a history of alcoholism, what have you. And it is lethal when ingested in a combination of benzos and alcohol, benzos and opiates. Okay. All right. So this is some independent study that you might find interesting. Okay, inositol, valerian root, lavender, GABA. These are supplements that can be helpful for treating anxiety. And, here's the thing about complementary treatment. The evidence is not as robust as the SSRIs, but it's not necessarily because they are ineffective. It's because they don't, it can be because they don't have big farm companies that manufacture Lexapro and Prozac funding all these trials. And that's a significant portion of it. So there is some research. There is the American Holistic Nurse Association. Look at their resources. You may have a patient who is really anxious and they need something, but they do not want to take medication. And the biggest thing is look at the evidence. Whatever evidence is available, look at it. Look at the side effects. What can you do? And also a very important thing, if you Google drug interaction checker, I think it's WebMD drug interaction checker. Let me look at it right now. It's drugs.com. They have a drug interaction checker. I always use it. So you always want anything that you suggest, you prescribe, you want to make sure you know what medications your patients are taking, and you want to document that the patient reports that they're taking XYZ, or you add that to their medication list, and you look in you add these drugs to your drug interaction checker, and you check the interaction of the multiple drugs or supplements. Okay? And I think that's it. So I hope this was helpful. I'm going to end it now. Wow, it's an hour.